Good afternoon. My name is Dawn McKnight, and I am the Executive Director for the Independent Association of Home Instead Franchisees. On behalf of the association, I would like to welcome you to today's webinar, Tips and Tricks for Navigating Third-Party Billing for Home Health Agencies with HDM Corp, who is a Home Instead vendor member. Before we get started, I just have one housekeeping item to share with you. Please type all questions into the chat as there will be a Q&A session at the end of the presentation. Now, I would like to introduce our speakers, Lisa Legowich and Maureen Jones. Lisa is the founder and chief executive officer of HDM Corp. Before establishing HDM, Lisa served as SVP of Healthcare Business Operations for Mutual of Omaha. Her staff of over 1,200 performed claim processing, customer service, and other administrative functions for both the group and individual lines of business. Lisa initiated Mutual's EDI vision. She served on the board of the work group for Electronic Data Interchange, WEDI. After starting HDM, Lisa expanded her knowledge of the provider's role in healthcare administration. Lisa brings decades of experience and strives to find a better way to administer healthcare based on a view of the whole process that benefits all parties, payers, providers, and patients. Maureen graduated with a Bachelor of Science in Healthcare Administration in 1998. She has worked at HDM since October of 2020, performing medical billing, coding, and credentialing for our clients. Prior to HDM, Maureen was the business administrator for a large physician practice for over 20 years. Maureen began her career as a registered nurse providing direct patient care. Her vast knowledge of the medical industry helps to serve our clients very well. In her spare time, she enjoys spending time with family, especially her two daughters, working on craft projects, gardening, and spending time with friends. Now, I'd like to hand it over to Lisa and Maureen to begin the presentation. So I think Lisa, you might be on mute.
Sorry about that. Thank you, Dawn, for the kind introductions. We want to welcome you today to our webinar on tips and tricks for navigating third-party billing, especially for the home health care industry. Dawn did a great introduction of our key players. We also have Lisa Dolan with us today, and Lisa is also very experienced in the billing area with decades of experience, and she has worked in various roles here at HDM and is becoming an expert actually in electronic data interchange as well. So she's worked with Medicaid, VA, home infusion vendors, and others in assisting our clients in getting paid by third-party billers. In this session, we want to ensure that you leave with ways to improve your cash flow and minimize hassles and stress involved with dealing with insurance companies and third-party payers. At the end of the session, you will be able to explain the third-party billing process for home health, identify key terms and definitions in the third-party billing process, determine common pitfalls in the third-party billing process, analyze the impact of EVV on your billing practices if you decide to work with Medicaid payers, and formulate ideas to improve third-party billing. We hope that you'll leave today with some clear ideas of how you can improve your process. We also are pleased that with these learning objectives, you should be able to apply for any continuing education credits that you might need, and we're happy to help you with this. So at the end of the session, we do have some contact information, so feel free to reach out if you need anything else in order to pursue those. Next, I'm going to turn it over to Maureen, who will provide a step-by-step walkthrough of the billing process.
Hello. The first thing we'll be talking about today is credentialing. Credentialing is a vital part of any facility or organization. This is going to determine if you get paid but also how you are paid. There's different ways that you can be credentialed. You could be in network, which means that you're going to be paid according to a contract or a negotiated rate. Usually if you are part of Medicaid or something like that, or even if you have VA claims, you have to be credentialed with either Optum or TriWest, depending on the area that you are in. And if you're out of network, some insurance companies will not pay you at all. So it's very important to know whether or not you need to be credentialed or not before you just start seeing clients. Once you are credentialed, you need to usually re-credential at an interval that's determined by the insurance companies. And these can vary, but most generally they're every 2 to 3 years. So you need to keep track of when you originally credentialed. Usually when they send you documents, it's going to tell you when you need to re-credential. It'll say that they have you credentialed until for 2 years, and it goes by the date of the letter. So you just need to pay attention to what that is. And when you do the credentialing process, you're going to need to have important documents ready. Either if you're doing it online, you need to have them uploaded on your computer so that they're ready to put onto that credentialing. And those are information such as your tax ID, your NPI number, any licenses that you may hold, or anything else that's needed to complete the process. If some of the companies too, if you're going to be doing EFT payments, they're going to need you to have your information for your banking, like a voided check or whatever, readily available as well. The next thing we'll be talking about is authorizations. And the authorization to services is what is required both by VA and Optum and TriWest. And also Medicaid usually requires you to have an authorization on hand. The authorization is important to read because it shows you exactly what services you can provide to that patient or client. And it shows you how many hours of service they're eligible for. This authorization number is required to be included in your claim form when you bill for the services. So you need to make sure that you have that proper authorization in hand and have that number. Most time and attendance systems, especially we work a lot with WellSky is one of the main ones we work with. It does allow you to set up an authorization in your system. So it has all that pertinent information on it, such as like the auth number and their insurance ID number, et cetera, on there. And so that it automatically will enter that onto your claim form, especially if you're entering it, sending it electronically. But you also need to have something set up that lets you know when this authorization will expire. Some of the time and attendance systems do have you put a stop date in on that so you can see that it's, that it's coming up. But you also should either put it on a calendar ahead of time so that you know that that authorization is going to expire soon so that you can get the paperwork in process to get a re-auth. So you could also, if you have just like a paper document of some type on your computer with all your clients' names and when their authorizations are set to expire, so you can look at them like the month ahead and see like, okay, these auths are going to expire in November. I need to get going on these and get those reauthorization paperwork in. The biggest issue that you have for unpaid claims a lot of times is that you have the incorrect information that's on your authorization in your time and management system. Either have a wrong auth number, it's been keyed wrong, or incorrect hours, something like that. So that's the biggest problem that you can have. So the authorization is one of the most important steps that you have when you're doing your billing. We're going to talk about some documentation of what you need. Medicaid especially, and is required that you have documentation in hand, and so does Optum and TriWest if you're billing VA claims, especially if you are audited. So you need to make sure that you do this so that you're paid appropriately for your services. This includes documentation of your ADLs and IADLs that you provide by a home health aide, and it also includes vital signs if a nurse is doing an assessment or a visit. So you need to make sure that you have those. Most of the time in attendance systems do allow to have this documentation in there, and it's usually set up at the time when your visits are scheduled, and that tells you what you're supposed to be performing. And then there's usually like a check off list that you check off that you've done each of these items. If it does not allow you to do this, you need to have a paper form of some type that you can fill out and do the checks on, and then also scan them into your system so that you have it with your documentation. This documentation helps you to prove what was done at each home visit in case you are ever audited. So if it's automated in your time and attendance system, be sure to check with your vendor and make sure that you see how long this is stored for. Some things, depending on the vendor, some only keep it in your record for 2 years, some are 5 years. So it kind of just depends. So you need to verify how long it will stay there. We're going to talk next about electronic visit verification. And I know this is something that's fairly new in the state of Nebraska, where we are located, but in all states, you know, they're all going to the same thing where it's going to be required. And this is thanks to the 21st Century Cures Act, which is the technology that records the details of services that are provided to the beneficiaries in their homes. This came about because it was to help ensure that the beneficiaries are receiving the in-home services that they are entitled to, and that they're not being shorted of any type. So this federal requirement, like I said, is that all states implement an EVV system for Medicaid funded personal care services and home health services. So any type of in-home visits, they require this to verify that you have provided those services. The requirements that are required for this EVV is data service, the location of your service, and I know for one, most of them have mobile type services that are on the phones of the home health aides and homemakers, and it shows their GPS locations when they arrive and they have to check in. It shows that they are at that home. So it also has the type of service that is provided, like homemaker or personal care. It gives the name of the individual that provides the service, so the caregiver's name, and also the patient or client name for the individual that's receiving the services. And it shows the time the service begins and ends. And all this is a requirement that your system has to have. There's many different EVV vendors. They have some that are like add-on type services or that interface. They're commonly for use with WellSky, but there's Sandata, there's NetSmart, also known as TELUS, Access. And then there's some home health care packages that have built-in software, like Access Care or Alora Health or ERSP. Those are all built within their system that send as well. The next thing we're going to kind of talk about is procedure codes. So if you do any type of a billing, these are very important. And it's important to know that there are two different kinds of codes that you use. The first one we're going to talk about is the procedure codes, are also known as CPT codes. And the codes are used to show what type of service was performed. It's also, the procedure codes are based on the time to show what services you provided, and they're either usually by 15-minute increments or by an hour increment. There's also some that are daily visits too, if you're have like a adult daycare type service. Some codes are paid by one payer but not another, and this can be an issue if you have clients that have multiple insurances, especially if they have like a commercial payer and Medicaid as a secondary payer. An example is most homemakers and home health aides, we're using the code GO156. And for Medicaid, they required a T1019 usually. Well, they don't pass over well from one to the other. So if you file it with their primary and you have to file it with a secondary, the code could be a problem. So that's one thing that you need to watch for if you're billing those type of services. Medicaid generally puts the codes that are payable on their authorization. So it'll actually give you a code like T1019 or S5130, whatever code they're going to pay. There is a free website that you can use to look up these CPT codes. And Lisa has posted this in the chat so that if you want to copy that, this enables you to be able to look at those codes so that you can see how they correspond with the services that you are providing. The next type of code we're going to talk about is a diagnosis code, which is also known as an ICD-10 code. These codes are used to show the problems that that patient or client has and why they need home health care. If you have an authorization for treatment, they usually give you the appropriate code for billing with your claim. Now, the VA, like Optum and TriWest, for sure put those on. Some of the Medicaid products do not have those on, but most of the time, if you're filing electronic claims, you do need a diagnosis. So sometimes they use a more common one that's just a code that tells you that the patient requires services because they're unable to take care of themselves or whatever. There's like a Z74.1 or Z74.2. These codes, there's also a free lookup for these codes as well. And Lisa has added that also into the chat. So if you want to ever look up a code, this is a very usable type of website. You can put it in by name. You could type in like the name of the disease, like diabetes, and it'll show you all the diabetes codes, or it'll show you codes that are along with it. The next slide, I kind of have an example of a code. And I'm using Parkinson's disease here because there's a lot of patients I know in home healthcare that do have this. If you notice right ahead of where it has the code, like the very first one on the top line in blue, it says G20 for Parkinson's disease. But if you notice on the left-hand side, there's a red arrow. That signifies it's not a billable code. It will not be paid by insurance. And the reason why is because they want it broken down more to tell you what other problems they have. So if you look at the ones underneath, they all have green arrows, so those are payable codes. Most generally, you're using like an unspecified code because usually you don't know the other issues and problems that they are having. So it would be like a G20.C, which is the very bottom code at the very bottom. And you see it says it's Parkinsonism unspecified. So if you don't know exactly what all they have, you'd always want to use an unspecified code, but you want to make sure that that code is in green on this website. If it's not, it will not be a payable code, and the insurance company will usually deny it. So we've talked about some codes here. And the next thing would be like your claims and your claim submissions. There's two types of services that you provide that can determine the type of claim you submit. So there's a professional claim, which is also called a CMS 1500. This is a form that most home health services can use to cover their items. And it's usually in the setup of your time and management system that you tell it what type of claim that you have. There's also an institutional type claim. It's also called a UB04. This is usually used to submit if you do bundled services. They usually require it to be on a UB form, or some of the Medicaid services from different states require it also to be on a UB. Most generally, institutional claims are done by hospitals, though. So generally, a professional claim is what it would be accepted in your case if you're filing a claim. I'm going to turn it back over to Lisa Leckwich for a moment, so she's going to talk about some other things with third-party billing.
So there's multiple ways to submit your claim, but they're not all created equal. So I'm going to go through some of the pros and cons of the different ways to submit a claim. And many of the differences really don't come into play until you're actually maybe needing to resubmit or submit a corrected claim or do an appeal. But on the next slide, we show that one of the important things that you have to have is proof of timely filing, POTF. When you submit a paper claim, you have a physical copy of the claim if you keep one. But if you mail it in and you don't do that with some kind of tracking mechanism, you will not have proof of timely filing. So if for some reason that claim doesn't get to the payer or the insurance company, they're not going to just take your word for the fact that you mailed the claim in on such and such a date. You need to have some tracking of that. So while paper claims, it seems to be easy and we can just drop them in the mail, it all works fine until it isn't received by the payer. The other thing is a lot of payers delay. It takes them longer to handle the paper claims. And so you'll see sometimes delay in your payments and cash flow. You can, to many payers, fax a claim. Not every payer does accept faxes, but many of them do. Again, we've seen situations where people don't keep the confirmation and the paper copy of the claim. They maybe had it for a while, but then they get rid of it. And when they need it, they don't have it. And again, it makes it very difficult to prove that you actually sent that claim if you don't keep that paper copy. When you submit claims into the portal of the payer, some of the portals are very good about allowing you to have copies or look up history or have a record of that claim, and some of them don't. So be careful when you do that. Make sure that you get some record of having done the activity, or that you can go back in and find that information. Of course, today, most claims are done through electronic data interchange. And I'm kind of biased, having been on the WEDI board and started this whole thing in practice. But with EDI, you do get a proof of timely filing, and you can look it up on your clearinghouse information. And you can also typically produce a facsimile of the claim if you need it at those times when you would have to do either corrected claim appeal or some kind of reconsideration. So we really recommend using electronic data interchange when you're submitting your claims. So I'm going to turn it back to Maureen again, so that she can talk now. You've submitted the claim. Now you're going to start getting your remittances and payments, and she's going to talk about how to handle that.
Hi, yeah, before I go into that, I just wanted to add a couple more items about proof of timely filing. You need to keep in mind that it's different with each insurance company too, of what they will accept. So you need to make sure that you know what those differences are depending on the payer. And the timeline for submission varies with each company, but it could be anywhere between 60 days to 1 full year. And it's also a difference between denied claims and rejected claims. And Lisa Dolan's going to be going into that more in a little bit, but just know that denied claims can be corrected up to 1 year sometimes for VA claims, but it does vary by payer. However, rejected claims do not count as a timely claim ever because they're usually not put into the system. So just keep that in mind, the denied versus rejected. And this also can vary if you are or are not a network provider. If you are a network provider, the timely filing depends on what your contract states. So you need to look at your contract to see. Sometimes the timely filing is 90 days, but if you're in contract, they'll make it say 120 days. They give you an extra 30 days. Sometimes it's the opposite. They give you less time if you're in network because they figure you should know what those timely filing guidelines are. So make sure if you are a network provider, you read your contract carefully. If you are disputing a claim for timely filing, you must show proof that the claim was initially submitted timely, which is why your method of claim submission is very important, like Lisa was talking about. If it's paper or fax, chances are you don't have the proof that you need. And even if you put it in their portal, if you don't have documentation that shows all the information that you really did get the claim submitted, that may not work either. But usually the electronic method is the best way to have proof of timely filing for your claims. The next thing we're going to kind of talk about is remittances and payment posting. Obviously, you've provided the service, you've billed for them, and now you expect to be paid. So we're going to talk first about the remittances. And remittance is just another name used for payment, essentially. There's different names and methods for payment receipts. And these can range from different things from EOB, which is an explanation of benefits, which tells you what benefits they paid for, or an EOP, explanation of payment. There's also a BOP, which is a bank option payment, which is most generally like a type of credit card payment. There's ERAs, which is electronic remittance advice. And this usually if you file electronic claim through a system, most of the time you can get back an electronic remittance too that comes back from your clearinghouse. Some people though even pull their claim payments from a portal such as Availity or Optum, or even the Medicaid portals have them as well, where it has the remittances where you have to go in and pull them out from their own system. Payments can also be received in many different ways. You can get a paper check in the mail that's usually accompanied by a remittance or EOP or EOB. You can get an EFT payment, which is a payment that you receive by direct deposit into your bank account. If you currently are receiving some type of payment that's not EFT, you should consider moving to EFT. It's the fastest way you can get payment and ensure that that payment gets into your bank. Even in insurance companies, if they're mailing paper checks, there is a chance you will never receive that check. It could go elsewhere or get lost in the mail or what have you, get lost on somebody's desk in a pile. I know that can happen too. So if you get an EFT, you know that money is going to be safe and secure in your bank account. And of course, I already said the BOP is a payment that is usually made via a credit card. They send you a virtual credit card in the mail with your explanation of benefits, and then you have to enter the credit card information into your system to get paid. So when you're posting those payments, you need to, the payments that are received for the services that you've received, you should make sure that they're posted properly to the correct dates of service or invoice. This is the best way to know that you're actually getting paid for all the care that you provided for that client. Any claim that is unpaid or partially paid will have a claim adjustment reason code and or a remittance advice code, which tells you the amount that was not paid and who was responsible for that amount. The first thing we're going to talk about is the remittance advice remark codes. And Lisa, there's also a website that has this information on it, and I think Lisa's going to put that in chat for you as well. Those remark codes usually have an M, a MA, or an N, which is followed by a number that states why it didn't pay. So it'll tell you specifically. And then the claim adjustment reason codes is usually in conjunction with that. It gives you a little bit more information. And they can start with a PR, which means patient responsibility, or it's due from the patient, or a CO, which is a contractual obligation, which says the facility cannot bill that patient and is usually considered a write-off. However, there's some denials that are in error, and a corrected claim can be submitted to try to get the payment for those. So just because it says CO doesn't mean it's the end of the claim. You need to really check into it to see why they're saying it's a contractual obligation. And when you have these codes, they're also followed by a number that states why the claim should be adjusted or billed to the patient. And these are called claim adjustment reason codes. And Lisa's posted that in the chat as well, so that you can see what those codes are. So for example, if it says CO 29, that's usually the code that signifies, the 29 signifies that it's a past timely filing claim. So you just have to learn about reading for those codes so you can tell what they mean when you see them on an EOB. The next thing is Lisa's going to be talking to you about some denial codes.
Thank you, Maureen. My name is Lisa Dolan. I'm not to be confused with Lisa Lokowitz. I'm going to be talking about the denial management. Reject versus denial. There are two different things that can happen with a claim. When a claim is processed by the clearinghouse, it will be either processed as paid or it won't. If a claim is not processed, the claim could be either rejected, which means it was never processed through the payer system and a remit generated, or it would be denied, which means the payer processed the claim in their system and then denied the claim according to the claim adjustment reasons that Maureen discussed earlier. Some of the reject reasons and where that could come from is, first of all, could be the rejected by clearinghouse. This usually happens if you are doing the EDI submission. Of course, it will not happen if you're doing a paper claim. But if you are submitting your claims electronically, you could get a rejected message in your clearinghouse software. Some of the things that could happen that are pre-screening to send the claim would be missing mandatory fields such as a date of birth, the name, or the member ID for that insurance company. There could be payer-specific requirements that are required on each and every claim that the clearinghouse has added to their edits, such as possibly a taxonomy code for that payer or a legacy provider number. A lot of times for Medicaid, that's required on the claim, and they already know that, so they've added it to their edits. And these rejections are shown in the clearinghouse program. If Between the clearinghouse and the payer, there can sometimes be an intermediary that also can reject a file. A lot of times that may be because the patient is not shown in that payer's eligibility file. This is also in conjunction with an EDI submission versus a paper claim or a fax or portal. If it's rejected by payer, that can also show up inside of a clearinghouse software program, but you could also receive it by paper. Some ideas that would reject for a payer is it's possibly past the timely filing requirements for that payer, or specific requirements, again, such as taxonomy, legacy, or additional fields may be needed in order to file the claim, and they are rejecting it prior to getting it into their system because they know it will not be able to be processed in full. Again, you would find these rejections either on the clearinghouse site, or a paper letter may be sent out to you from the payer explaining what is done. Generally, if it's not on a remittance advice and you get the letter, there is not a claim ID for that claim. So that's also going to be an indication of how you file that response to that claim. Rejected claims are not considered clean claims. The claim does not go through the payer system. These claims need to be reviewed immediately for the rejection reason. Once the claim was corrected, it should be sent back as an original claim because, again, it did not receive that ICN number that is generated from the payer system. Submission dates on rejected claims are generally not considered as a legitimate proof of timely filing, as Maureen said. The date of the claim is processed through the payer system would be considered the first submission date, aka proof of timely filing. Some of the denial reasons that can occur, that means that it has gone through the payer system, are specific payer requirements, again, possibly an incorrect modifier, legacy number, or taxonomy. It could be that the authorization specifies correct units and you have exceeded those. A claim was previously submitted and possibly it's denied for a duplicate. Or lastly, maybe the provider will not be allowed to bill for services on the claim because it was part of a bundled CPT code or not. Denial claims have been processed through the payer system, then an remittance would be, as Maureen mentioned, would be generated. Those codes are sometimes denial codes and such that you would have to pursue. So you do need to refer to that list and understand what those reasons are. They also need to be reviewed timely because they need to be sent as a corrected claim. Because it has gone through the payer system, it should be sent as a corrected claim, and the initial submission claim ICN number should be added to the claim. Also, a note should be added as to what you are changing on that claim so that it helps the adjusters as they're looking at the claim and seeing the differences so that it will be a better chance of being processed correctly. The initial claim submission on denied claims is the date that would be used as a legitimate proof of timely filing. So you would need to get that from either, as Lisa previously said, your paper submission, your fax submission, but the best one is EDI. The next topic we're going to talk about is that as part of that follow-up, you'll have those denials that we just referred to as part of that cleanup, but there are other things also. You would first of all follow up regarding because of that notification of reject or that denial remittance. If everything looks good on the claim, but it's still rejected, there's some other things that you can do as far as follow up. We all have billed claims for the same patient or starting a new patient, and we think that we've entered everything correctly. It's always good if you think everything looks right on the claim to go back to the source document where you got their correct spelling of their name, their date of birth, the member ID, a social. Go back to the original auth and make sure that the auth number is correct with those dates and those units. That's always good to re-look at those. If you think everything's correct, let's just make sure one more time. Denial reasons could also be based on system edits or the manual processors that look at these claims, and the code reasons may not be for the true reason of the denial. Payers have changed edits in their system and have caused unknown errors in processing other claims. Both of these things require you to review the claim. And if everything still looks good, the best option is to call. If it's a rejected claim, calling the clearinghouse would be your best option. To clarify that, they do have people on staff that usually can help you. It is sometimes a payer issue, and in those cases, you would need to call the payer. For any follow-up that you do, you should always document what you have done. Document that call, because if you need to do additional calling, they're going to want to know, well, who did you talk to? So first thing, date and time of the call. Everyone that you have talked to, put their name down as to who you talked to and possibly their title if they provide it to you. And then what was done? Are they going to reprocess the claim? Are they going to escalate it to a supervisor? Do you have to do an appeal? That will ultimately help you with the appeals that we'll talk about later. The next thing is as you're on the call with that payer, if the answers do not make sense, you understand how to bill something, but your claim still is not reflecting that it's paid based on your knowledge there, ask for a supervisor. Don't be afraid to escalate it. There are times that first line of customer service is not aware of all the different possibilities. In some cases, these customer service people are going across multiple specialties within the medical industry. They could be doing radiology, they could be doing ambulance, and to know all the specifics on home health, sometimes it's best to ask for a supervisor who has a little bit better knowledge. The last thing is that if you feel like that one is still not quite understanding you, don't be afraid to hang up the call and ask for, dial that payer again and get someone different. Every person's knowledge and training is different within any organization. And as you probably know within your own, it takes time to learn these different nuances within the home health field. And so someone else might have a little bit better knowledge of what you're trying to discuss. These are some options with follow-up so that you don't just let claims go unpaid. Another part of the appeal or follow-up process is to review your AR reports. If you only look at the remittance advices or the reject notifications, that's not a complete picture of your claim portfolio. There may be claims that never ever got a remit or a denial to trigger you to do something about it. Every 30 days, you should run a report on your AR and look at those claims that are greater than 30 days. Now, this may need to be sooner if you already know what the payer can provide. For example, if the payer is paying claims within 30 days and their timely filing is 90 days, the AR should be done no later than the 45th day to ensure proper handling of that claim so that you have time to send a corrected claim, to call on it, to do what you need to do, because ultimately you are trying to achieve 100% maximum revenue for your business. Claims on the AR report that were never received, payment could also be due because there was an issue with the clearinghouse processing the batch. Follow up with them and make sure, did my claim get to the payer, because they either don't have it or they're not issuing me an EOB back, and you need to find out why. The best place to start is the clearinghouse. Second of all, there could be an issue just with you not receiving remits. Verify that you are receiving remits from that payer. And if you're not, then again, reach out to the clearinghouse to make sure that that enrollment is done. Or if you get it by mail, verify that they are still sending out checks for other patients. It could be a payer issue. Recently, as you know, we've had Change Healthcare had a cyber attack. It did interrupt payments and getting remittances so that you knew what happened with the claim. It could be claim edits within the payer system that has stopped you from getting those remittances so that you know what happened with that claim. Overall, with follow-up, it's always best to look at every claim and to make sure that it has followed from submission to payment in order to make sure everything goes well. But there are times when no matter who you've talked to and how you've created that claim, appeal may happen. And so Maureen is going to take it from here.
The next part of the process, if you have a claim that hasn't been paid or was denied, especially for timely filing, would be by doing an appeal. And different companies have different types of appeals that you need to do as well. But the documentation used for your appeal is the important key in the process. As you can see on the next slide, I know Lisa just talked about some of this, but these are all important things. You need to document any calls that you make on the claim with the date of the call, who you talked to, and be sure to get a reference number for that call. Write down exactly what that customer service rep told you, because they might tell you that you need to do a consideration or an appeal on the claim. Ask them if there's a form that they use, and if so, how do you find that form? Is it on their website? If they want a letter, be sure to ask them what needs to be submitted with the letter, any additional documentation, and what address or fax number do you need to send that to. You know, all the insurance companies have different ways and forms that they want to appeal your claim. Usually there's a form found on the website of the insurance company, or it'll tell you simply that you need to submit a letter. But you need to be specific in your appeals if you're writing a letter. And I usually start off mine by saying, I'm appealing this claim denial because, and I give them the examples, you know, I feel it was submitted on time. Here's my proof of timely filing, et cetera, et cetera. And then also tell them what you expect. You know, I expect this claim to be paid because it was filed timely, whatever. The more detail you give, and the more they will understand the issue that you have with that claim denial and be able to help you with that. Sometimes you need to get compliance officers at individual companies involved as well. So you need to involve someone higher up than just the customer service rep. And sometimes even the supervisor can't help you as well. And finding this information can sometimes be difficult. You can ask the customer service rep how to get in touch with their compliance officer. A lot of times they don't know. Sometimes the company website will have that information as well. But usually, you know, you just need to be specific about asking who that compliance officer is if you need to get in touch with them if something's not getting paid or you're having issues. One of the services we do offer is called our QREC services, and we help you if you're unsure of the process of how to do an appeal. And through consultation services, we can help you, or by actually doing those appeals for you. So keep that in mind as well. Here's Lisa. She's going to tell you a little bit more about HDM and the services that we do provide.
Yes, before we open it up to questions, I do want to do a small commercial break. In summary, at HDM, we provide a myriad of services to fit your billing needs. Our service offerings are flexible and can assist in ongoing. We can fill temporary staffing needs. We can handle a group of claims or appeals, or we can just help you with one claim. Your need is what drives our services, not the other way around. One of our most popular services today, since we believe in electronic data interchange, the best way to go is the best way to go. We've partnered with Waystar to offer this service at a reasonable price. Waystar is considered a best-in-class EDI platform. CLAS is a research firm that provides unbiased feedback and insights on healthcare IT products and services. Waystar is highly rated due to its ease of use and its robust front-end editing. We've wrapped this into what's called HDM's Quick File product, where we have our white glove service. Imagine being able to call into your customer service and talk with experienced home healthcare billers when you have a question. At HDM, we really care about you and getting your claims paid, and that's what makes the difference in our clearinghouse services. We also work with various agency management systems and are able to fully integrate this process, assuming that your system can handle it. I assume most of you do use WellSky, and this is a vendor that we work closely with and can easily set up a fully automated billing process for you. In most cases, that not only automates the front end billing, but also in most cases automates your payment posting as well. So we also believe in transparency, and our pricing is just $80 a month for 100 claims or less. So with that, we'd like to open it up to questions at this point. if anybody has any questions, please let us know.
Yeah, I put a message in for people to type questions in the chat.
Okay.
So we'll wait a minute and see if we get any. But great presentation. Appreciate you guys spending the time putting this together and, you know, providing some valuable information to the association members. You know, just helping them do their businesses better. So it's certainly an important, important aspect of what we like to provide. And we appreciate you being a vendor member of the association. So I do have a question. So there was quite a few people that registered, but some people obviously couldn't attend, and that happens with conflicts. So I am going to send out the recording to those that registered. And if there's information that you would like me to include in that, you could send it my way as well. The contact information, which I can see that right there, right? So if anybody has additional questions, it's going to take me a couple days to get the recording out. Lisa has her phone number and her email listed on this last slide. Please don't hesitate to reach out. And if for some reason you need her information and did not write it down, you can reach out to the info@iaohif.com. That comes directly to me, and I will connect you via email with Lisa and the team.
Yeah, and Dawn, if you want to go ahead and put my contact information in the email, you know, in the front end of the email as well. To
I
let
will do
people
that.
know. Yeah, that'd be great. That
Phone
would be
number
great.
and email is fine.
Yeah, that'd be great. Thanks.
Okay. Yep, I will go ahead and do that. And yeah, all right, I'm not seeing any questions. So that means you guys did a fantastic job covering all of the information. You didn't leave any holes where people have questions. So I want to thank the three of you, Lisa, Maureen, and HDM Corp, for again being a partner for the association and taking the time to provide this information, and for the attendees on the call. Thanks for your time this afternoon, and I'll be sending out the presentation to everybody that registered, and then I'm also going to post it on the back end of the website behind the member wall, and let those that couldn't attend for whatever reason know that it's there so that they can take advantage of this great opportunity. And I just want to wish everybody a great rest of your day.
Yeah, thank you all. We appreciate your time. Thanks,
Thank you.
Dawn, for setting it up.
You're welcome. Bye-bye, everybody.
Bye.